Good morning. Hello, I'm Dr. Rob Rozbruch from Hospital for Special Surgery, and we're going to be discussing new strategies for limb lengthening and reconstruction, particularly in Russell-Silver syndrome, which is a congenital leg length discrepancy type condition, as an example. This is a reproduction of a lecture that I gave at the MAGIC convention in Lombard, Illinois on July 16, 2019. The MAGIC convention is a meeting of healthcare professionals and families and patients who have this condition. It's actually a great resource for education, both of professionals and of patients and families. These are my disclosures. There are some parents and children whose faces are shown, and they have given consent for this purpose. I want to acknowledge Dr. Madeline Harbison, who is a pediatric endocrinologist and who introduced this condition, this topic to me many years ago, and she and I have collaborated and treated many of these patients together. And together, we have developed what is probably the largest clinical experience in the world dealing with the musculoskeletal issues that are associated with Russell-Silver syndrome. So some of this lecture is going to be about basics, and some of it's going to be a little bit more esoteric, and I think hopefully there'll be something to learn on all levels. There are various causes of leg length discrepancy in children, and this includes congenital, traumatic growth arrest, overgrowth, or neural inhibition. And this schematic kind of shows the typical way that we will evaluate leg length discrepancy. And we use a long x-ray that will show us the relationship and alignment of the entire lower extremity, including the pelvis, the hips, the knees, and the ankles. And it works out best when you're examining a patient clinically and also when you're doing an x-ray, if you can anticipate what block or what leg length discrepancy is present to optimally level the hip. And you can use it, you're going to get a more accurate calculation in doing that. Sometimes you're going to be perfect and the pelvis is going to be perfectly level, and sometimes you're going to be a little bit off. But nevertheless, having a block in there with some degree of equalization, if not perfect, will make this measurement of leg length discrepancy better. It allows you to measure total leg length discrepancy and segmental differences. Now, leg length discrepancy leg length discrepancy affects alignment of the whole body. And principally, the way it works is that if one leg is shorter than the other, there is pelvic obliquity. Pelvic obliquity has a deleterious effect on the spinal-pelvic relationship and the subsequent spine that is above the pelvis. And so this is associated with a condition called leg length discrepancy induced scoliosis, which is not real scoliosis, but basically it's just a compensatory scoliosis that occurs because the pelvis is not aligned. Essentially, the floor is tilted, the floor being the pelvis, so the spine is curved. Now, you can see here in this other schematic, here you can see there is leg length discrepancy and there is scoliosis. And typically, what happens is that as you correct the leg length discrepancy, here illustrated with a lift, the pelvis is leveled and the scoliosis or the back curvature is resolved. So that's our goal with correction of leg length discrepancy. When dealing with congenital leg length discrepancy, and Russell-Silver syndrome is a condition that is an example of a congenital leg length discrepancy pattern. There are a number of factors that are important in the clinical decision making, and this includes the age of presentation, the current leg length discrepancy, the distribution of the discrepancy in the femur and the tibia, the patient's bone age, the multiplier, and the compliance with the use of a shoe lift. Now, the treatment options are going to be one-stage lengthening, 2 or more stages of lengthening, and then the decision also has to be made about which segments are addressed, femur lengthening or tibial lengthening. I'm going to try to illustrate some of this decision-making with a variety of cases to help understand the way we approach this. Distraction osteogenesis is the predominant tool that we use for bone lengthening. So distraction osteogenesis is a brilliant biological, physiological phenomenon that was discovered by Ilizarov about 70 years ago now. And the idea is that you can cut a bone and bone will regrow bone because bone as a tissue has regenerative ability. And what distraction osteogenesis does, it takes advantage of the ability for bone to regenerate. And while it is regenerating, the bone is gradually pulled apart. So in doing that, these bone-forming units stretch and lay down increasing amounts of bone. This was beautifully illustrated in some drawings by Dr. James Aronson. And what he's showing here is an enlargement of the bone-forming unit. And so there's a lot of neovascularization, a lot of new growth of blood vessels and various growth factors. But the bottom line is that bone actually is growing, and you can see it illustrated here. And you can see it's being stretched, and it's growing from the periphery, from the proximal end and from the distal end. And then the middle part, or the interzone, is the last part of the bone to heal. When we talk about bone lengthening, there are a couple of different phases. I mean, first there's a latency phase, which is just the amount of time that you wait from when you do the surgery until you begin the distraction. But the 2 main phases are distraction, which is the actual elongation or pulling apart. And here you can see it illustrated with an internal lengthening nail at the early and middle stage. And consolidation is the hardening or the mineralization of the bone until it becomes structurally sound. Russell-Silver syndrome is a rare condition, but leg length discrepancy is present in more than 90% of patients. And one might be concerned, one should be concerned about the potential of bone healing in this group of patients because they have inadequate caloric intake, and they tend to have developmental, physical developmental delays, and they tend to be small, and they have a failure to thrive as part of the natural history of the condition. They have absolutely perfectly normal mental function, and the short stature that is associated with this condition is typically treated with human growth hormone. And that's a big part of the strategy that has been used by Dr. Harbison, is getting these patients on human growth hormone very early, typically at age 2. And this helps them develop. They develop typically into a normal stature situation, and their size increases dramatically with human growth hormone. The details of that treatment are beyond the scope of this lecture, but the idea is, and the main concept vis-a-vis leg length discrepancy, is that this is a group of patients that is small in general starting, and they have short stature. The human growth hormone is used to help them develop more normally. So the concept of treating their leg length discrepancy with an epiphysiodesis or a bone shortening operation doesn't make a whole lot of sense. And so that's yet another motivation to use limb lengthening or bone elongation rather than bone shortening of the contralateral leg to deal with the leg length discrepancy. My experience with Russell-Silver syndrome, RSS, has not been to increase stature, because we have found that the use of human growth hormone achieves that goal in and of itself. So when we look at growth hormone, there are abnormalities of growth hormone secretion in many children with RSS. And human growth hormone has increased linear growth without concomitant increases in leg length discrepancy. Human growth hormone increases the total limb length, but does not change the congenital leg length discrepancy pattern. And given the frequency and severity of leg length discrepancy associated with RSS, and the average is about 3.1 centimeters, many patients will present for limb length equalization surgery. However, as I just stressed, epiphysiodesis is not a good option for the reasons that we discussed. So in the pre-internal lengthening nail era, where we were using only external fixators, I might approach a patient in the following manner. So this is a patient named Madeline who presented to me at the age of 13 with a leg length discrepancy of 5 centimeters that was divided evenly between the femur and the tibia. And she's pretty much at the end of her growth. She has a predicted leg length discrepancy of 5.2 centimeters. In this congenital pattern, you can use something called a multiplier at any given age, and there's a table of it for boys and for girls. And you can simply multiply the current leg length discrepancy by the leg length discrepancy at maturity, and that will give you the predicted leg length discrepancy at maturity. And so you can see as patients get close to the end of growth, and girls usually typically stop growing at around age 14, the PLLD here is 5.2 centimeters. This pattern of it being roughly equally divided between femur and tibia has been typical in RSS, and there isn't a whole lot of lower extremity malalignment associated with the leg length discrepancy. And so what I did here was I did a simultaneous femur and tibia lengthening, 2.6 centimeters in both the femur and the tibia to deal with the entire leg length discrepancy. It was a small enough lengthening in each segment that I felt comfortable doing them at the same time. And this was the approach. This is pre-internal lengthening nail. This was at a time when the internal lengthening nail was not available for use. We formed nice regenerates. This is the consolidation phase, both of the femur lengthening and of the tibia lengthening. And you can see the fixators. Patients are weight bearing as tolerated. The fixators are not connected, so they are bending their knee during this treatment period. And she ended up healing nicely. The bone consolidated well. It healed. The fixators were removed. I followed her for many years, and she ultimately had a very normal adult height. In fact, above normal. She was equal in height to her mom, and this was her. This was a very normal height given her family situation. Now, this was achieved entirely with the human growth hormone. It had nothing to do with the bone lengthening. The bone lengthening was simply done on the right side to equalize it in length to the left side. You can see the regenerate remodels to the point that anybody looking at an x-ray would have no idea that lengthening surgery was done on the patient. Here's another example of a boy, 12 years old, with a similar type of presentation, also RSS, had a leg length discrepancy of 45 millimeters, roughly equally divided between the femur and the tibia, and with a PLLD of 5.3 centimeters at maturity. So my approach for him was similar to what I showed you before. Here I'm showing you and illustrating how the leg length discrepancy creates this pelvic obliquity and the leg length discrepancy induced scoliosis. So we used a fixator on the tibia, and we used a fixator on the femur. You can see the regenerate bone in both of those locations. This is what the clinical setup looked like. In the femurs, we were typically using rail frames. Patients tolerated those better, and circular frames in the tibia. And at the end of the lengthening, he's all healed, and you can see his leg lengths have been appropriately equalized. What you'll notice is that the left side has been slightly over-lengthened, and that was done intentionally because of the predicted leg length discrepancy being a little bit more, because he still has a little bit of growth. And typically it's not significant, but you can certainly use a small shoe lift on the opposite side as a temporizing measure. Now, what I'd like to show you is an example of how I might approach that today in the internal lengthening nail era. And so this is an example of a 20-year-old male. This patient does not have RSS. He has untreated congenital short femur and fibular hemimelia. But it's a very similar type of presentation in that he has a total leg length discrepancy of 5.1 centimeters, and that it's roughly equally divided between the femur and the tibia. There are some particularities about fibular hemimelia, and you can see he's got a valgus deformity of his tibia, and he also has a short fibula, and he's missing rays in his foot. When you analyze this deformity, you can see by measuring the segment lengths that the LLD is divided between the femur and the tibia. And what you can also see is that these joint orientation lines confirm what we can see, and that is that the valgus is coming from the tibia. So my plan here was to lengthen the femur. There's no deformity in the femur, so just to lengthen the femur without correction of deformity. But in the tibia, I did want to correct the valgus deformity and lengthen simultaneously. So let's see how we did that. So in the tibia, we used a fixator-assisted blocking screw technique. And the blocking screw is placed in the concavity of the deformity adjacent to the osteotomy. You can see a single pin fixator is used above and below. We do the osteotomy, we correct the deformity, and insert the nail. Fibular length stabilization screws are necessary, proximal and distal. It's important to maintain this relationship so that the fibula is not proximally migrated, which could cause a problem. And at the end of the lengthening, you'll notice that he has regenerate in the femur, and he has regenerate in the tibia and the fibula. The alignment has been corrected, and the blocking screw has guided the nail to accomplish the intended correction of the valgus deformity. His pelvic obliquity has been corrected, and this shows the progression of consolidation in the femur and in the tibia, both of which healed really, really nicely. Again, this is an opportunity to help stress the importance of the blocking screw. And the blocking screw in the concavity deformity guides the nail and really allows it to correct the valgus deformity. So it's a very important part of lengthening and deformity correction when using an internal lengthening nail. So this is David, who at the age of 6.5, he does have RSS, and he presented to me with a leg length discrepancy of 6 centimeters. When you plug his numbers into the formula using the multiplier for his age, he has a predicted LLD of 10 centimeters. So my strategy in a child like this, since I'm seeing him earlier than the earlier patients that I showed you, it's an opportunity to treat this in 2 stages, which I think is a preferable way to deal with this. So what we did is we corrected the tibia length discrepancy first, and that's done with an external fixator pins, and osteotomy. And so goal number 1 was to correct half of the leg length discrepancy in the tibia. And again, remember I said that the LLD was roughly equally divided between the femur and tibia, which is typical of RSS. What you'll see here is he was developing a little bit of a flexion contracture of the knee, which is not an uncommon thing in children during tibial lengthening. And so we attached this little brace to the fixator, which helped to straighten out his knee, and that was very, very effective. You can see the regenerate bone in his tibia. And so what we were able to achieve is equalization of his current leg length discrepancy, understanding that there's going to be additional leg length discrepancy that's going to develop in the future. In the fixator, he was quite active, and this is him showing off some of his moves. And the point here is that we do encourage patients to be really be active, walk, and functionally use the limb during the healing process. You can see the regenerate is becoming more consolidated with time. And he's all healed. So I follow him, and so now he's age 10, so it's 3.5 years later. As predicted, you know, he's emerging some additional leg length discrepancy. That's what we expected. You can barely see where the lengthening was done because of the remodeling process of the tibia. But my plan is going to be in another 3 to 4 years to go back and lengthen the rest of the discrepancy, what emerges, and I'm predicting 5 centimeters, and we're going to do it in the femur. And we're going to be able to use an internal lengthening nail for that part of the treatment. So seeing patients at an early age gives us the opportunity to sort of understand what the current discrepancy is, chart out the predicted discrepancy, and come up with a plan. And I do think that treating this in 2 stages, particularly if you're dealing with a predicted discrepancy that is large, like 10 centimeters, it's advantageous to do this in 2 stages rather than 1 stage. The second advantage of doing it in 2 stages is that you are currently taking care of the problem for the child. You know, so the 6.5 or 7-year-old child who has a 2-inch leg length discrepancy and is wearing a big clunky lift is treated, and that discrepancy is resolved. And that makes the function and also sort of the psychosocial component of it improves that tremendously. And then the patient doesn't feel like they have a disability or a difference, and they grow up feeling much more healthy. And then you can just watch the emerging discrepancy that does develop, and then deal with the rest in a second stage. Here's another example of that approach. Here is Faith, who at the age of 8 with RSS presented to me with an LLD that is 4 centimeters. Predicted discrepancy about 6 centimeters, split between the femur and the tibia. So again, what I did was I did a lengthening of the tibia to correct the current leg length discrepancy. You can see the regenerate formation is really very robust, very healthy. And then she's done with her shoe lift. Then she has a few years of just normal activity without any shoe lift, without any leg length discrepancy. As predicted, what's going to happen is that as time goes on, and here I continue to follow her, and at age 15, she presents with an expected 2.5 centimeters of additional leg length discrepancy, right? It was kind of part of the plan, and you chart it out and you watch it develop, and then we come back and then we do a femoral lengthening with an internal lengthening nail, which is a relatively quick and relatively easy treatment, and that takes care of the problem totally. You can see the regenerate formation is very robust at 2.5 months after a femur lengthening procedure. Now, we published our results several years back on limb lengthening in children with Russell-Silver syndrome in the Journal of Children's Orthopedics. And we asked the question of whether pediatric patients with RSS and this group all treated with HGH would have a uniformly good bone healing following leg lengthening. And what we did is it was a retrospective comparison. It was a level 3 study looking at RSS patients with LLD on growth hormone. And our control group was the rest of my pediatric practice of general pediatric lengthening, which included other conditions such as congenital, post-traumatic, or post-tumor. And what we were able to show is that in the control group, the bone healing index was 43 days per centimeter, and the bone healing index in the RSS group was 29. So lower number is better. Lower number means that the bone healing is faster. And so we were able to show that the bone healing in RSS patients was superior, was faster, more predictable than a control group of pediatric patients, with the caveat that these RSS patients were on human growth hormone. So, you know, the conclusions of that paper were as follows. We know that these patients have functional limiting leg length discrepancy, but this has to be weighed against the concern about bone healing in this group of patients that might have bone healing issues. At that time, we noted that there was a scarcity of literature on this condition, and we also know that human growth hormone had known positive effects on fracture healing, although it had not been well documented for human limb lengthening. However, recent animal studies did show that growth hormone improved muscle recovery during limb lengthening. So what we were able to demonstrate, what we found, what we learned was that all of the RSS patients had a good outcome. And by the way, the reason it sometimes is referred to as RSS and SRS is Russell-Silver syndrome or Silver-Russell syndrome, depends on which side of the pond you're from. Because Russell and Silver, one was an American and one was a European. And so that's why you see it referred to sometimes. The fellow that was working on this subject was closer to the European side of the pond. And we had no significant problems in this group of patients. We had no premature consolidations on human growth hormone, and we had no HGH-related orthopedic complications. We found that the RSS patients uniformly had excellent bone healing. The bone healing index was significantly shorter than in the general pediatric population of treated at the same institution by the same surgeons. And we found that we concluded that human growth hormone may significantly improve regenerate formation and consolidation. Now, this is updated data as our experience has grown, and this is soon to be published. This will be presented this year at the Limb Lengthening and Reconstruction Society meeting, which is going to be in July and is going to be submitted for publication. This is an ongoing study that was updated and the lead was taken by one of our orthopedic residents named Chrissy Goodbody. And this is new bone healing data on 30 limbs in 26 patients. And again, we're seeing really fantastic bone healing indexes in the group of RSS patients. When we stratify them and separate them by femur and tibia, not surprisingly, we're finding that the femurs heal faster, lower bone healing index than the tibias. That's been the general experience. But nevertheless, you're finding a bone healing index that is in the range of about 1 month per centimeter, which is fantastic and very, very predictable. So here's an example of an adolescent with RSS who needed a 3 centimeter lengthening. Was done with an internal lengthening nail. You'll notice a trochanteric entry nail is utilized because the patient is still skeletally immature. And this has achieved a bone healing index with consolidation and healing across the regenerate with a bone healing index of 24. These are some features of the internal lengthening nail. The red arrow is showing you the magnet in the precise nail, and that spins from a remote control device on the outside of the leg, and that turns some gears and it elongates the telescopic portion of the nail. The regenerate is the space that is created between the two bone ends, and here you can see it. It's at a point, again, 71 days, where bridging bone has formed, and this is clinically healed at this point. Here's another example of a patient named Ileana. Ileana presented to me at the age of 8 with a congenital pattern from RSS. Her current discrepancy was 5.5 centimeters. Her PLLD, predicted leg length discrepancy, was 9.5 centimeters, and it was in the femur and the tibia. And my strategy was, again, to break this up into 2 stages. In her, stage 1 was the femur, because there was more discrepancy in the femur than in the tibia. And so we used a rail frame, and she had a very successful femur lengthening with excellent bone healing. And then I followed her for the next 7 years, and at age 15, now with her growth plates closed, she had developed an additional 5 centimeters of leg length discrepancy. Again, not surprising. This was part of the predicted pattern that we had sort of noticed all along. And at this point, we determined that it was safe to use a internal lengthening nail in the tibia. And so we did a 5 centimeter lengthening with a precise nail just at the end of skeletal maturity. You'll notice that her growth plates are closed. Now, this is an opportunity to point out that in the tibia, we really don't use the intramedullary nail until the growth plate is closed, because we don't want to damage the proximal tibia growth plate that this nail would need to traverse. But in the femur, you actually have the opportunity to use the internal lengthening nail at a younger age, because it does not affect the femoral growth plates, and it does not affect growth. This x-ray is at the end of the distraction, showing the regenerate, showing the equalization of the leg lengths, and then here you can see the progressive consolidation noted. Again, just some features of the nail. Here's the magnet. Here's the distraction, the distraction rod, and you can see the elongation of the telescopic portion of the nail. The bone healing was very robust, fantastic. What I'd like to show you, I want to switch gears for a moment and discuss the concept of simultaneous lengthening and correction of deformity, because this is a big part of limb lengthening in everybody, in adults and children, but we do see it particularly in children, and it comes up quite a bit in congenital cases and also in cases that are related to growth arrest. And so this was a multi-center study that Dr. Fragman and I did with some colleagues from other institutions. So this is the clinical scenario, right? Here you have a 15-year-old girl who has a post-traumatic growth arrest with a valgus deformity in her femur and a leg length discrepancy of 36 millimeters. So this is the treatment here is internal lengthening nail. This goes back about 15 years, okay? So I know that the valgus is coming from the femur. I plan my osteotomy and my deformity correction, and I do an acute correction of deformity with the rail frame, and then I do some subsequent lengthening, and this is what it looks like. This is what it looked like 15 years ago. Acute correction of the valgus and gradual lengthening with the monolateral frame. The bone healing was fantastic. She did really nicely. She went back to a very high level of athletic function. But what I do want to show you a similar case and how I would treat it in the internal lengthening era. Right here you can see a young man who has a very similar problem, valgus with leg length discrepancy. We do our planning, first mechanical axis planning, then anatomic axis planning, and we calculate that there's 8 degrees of deformity that needs to be corrected. And we use an internal lengthening nail, retrograde, for acute correction of deformity and simultaneous lengthening. Again, the strategies here require the use of blocking screws, and a fixator-assisted technique is essential. So what you're seeing here is acute correction of the valgus deformity. The blocking screws help guide the nail, and you can see the regenerative formation. When you do these retrograde nails in a situation like this, typically we're using a shorter nail because we have to respect the bow of the femur that the nail would not cross unless you did a second osteotomy. So let's look at Luke as another example. Luke has a posterior medial bow of his tibia. So this is not RSS. And he presented to me with a leg length discrepancy at age 6. And so you can see he's got 36 millimeters of leg length discrepancy. It's all from the tibia. And he's got a multiplier of 1.68. Again, the multiplier is right off of a table. It's based on the gender and it's based on the age of the patient. And in congenital patterns, you simply multiply the multiplier, this index, by the current LLD, and you get the PLLD, the predicted leg length discrepancy at maturity. It's a very, very accurate way of making this prediction, and it's constantly repeated because it's repeated every time you see the patient at different ages. And you're going to get different points that are going to be pretty similar. And you get by combining these points, you get a very, very reliable, accurate prediction of the LLD at maturity. So anyway, if you look at this pattern, he's got this compensated deformity of posterior medial bow with a little varus and a little valgus, but the overall alignment is not bad. He's in a little bit of varus. And so my approach here was to do a tibial lengthening now to correct the LLD, with the understanding that I was going to have to come back and do additional lengthening as he got older. What I did was, rather than trying to do a double level osteotomy, I made a single level osteotomy and just did some minor adjustment of the alignment, of the lower extremity alignment, in order to correct his mechanical axis optimally. You can see the regenerative formation is very, very robust, very satisfactory in the tibia. Again, these pictures illustrate that we try to encourage our patients to be quite active while they're wearing the fixators. It's not torture. They can actually be quite active, make the experience a positive one, and the more active they are, generally the bone healing is going to be faster. But nevertheless, when they do want to get that fixator off. And as you can see, Luke expressing that to me on the day of his removal. So my lengthening achieved, you see, just by tweaking the mechanical axis, I was able to get his mechanical axis straight, and we've equalized his leg lengths for now. And as predicted, he's going to grow additional LLD into the future. So add 5 years. Now he's 13-year-old. He's got different interests than he did when he was the little boy that I saw him last. He's playing lacrosse. He's busy. He's got an active social life. And he's got, at this point, a predicted leg length discrepancy that is an additional 2.8 centimeters. Very, very similar to what we had predicted initially. Of note, the tibia did not remodel, the mechanical axis is neutral, and the leg length discrepancy is all coming from the tibia. So the question is, what do we do now for that leg length discrepancy? And the options are to either do it in the femur or the tibia. Now, the tibia is the place of the leg length discrepancy, and so certainly I discussed that with the patient and the parents as a primary option. However, there are some drawbacks with it. He still has an open growth plate, and he's got this remodeled deformity. So he's really not a candidate for an internal lengthening nail. And so if I was going to do it in the tibia, I was going to use a fixator again. Again, it would have worked nicely, but it would have been in the frame for a few months. And the other option I presented to them was using an internal lengthening nail in the femur. Now, the big advantage of doing that is the ease of treatment and the time of treatment. No fixator, much quicker result. That's at the expense of accepting a mismatch in the height of the knees by 2.5 centimeters. So we discussed the pros and the cons of it, and for this particular patient and for this particular family and his needs, he definitely wanted to do the lengthening in the femur, and that's what we did. As predicted, the healing was quick. It took about a month to get the length, and then about a month after that, he was fully weight-bearing. And just to illustrate, you know, the speed of the healing, he sent me this photo of him snowboarding, excuse me, just 6 months after the surgery, which is really pretty phenomenal, you know, if you think about it. That's quicker healing, much faster return to normal than what we would be able to see with a fixator. And as his mom commented, happy kid, happy parents. So they were very, very satisfied overall with the treatment. The internal lengthening nail, the precise magnetic internal lengthening nail, really came into use at the end of 2011. So we're about in our 9th year of using it, and we were very cautious at first because there had been previous internal lengthening nails where the control of the lengthening had not been as desirable, and so we looked very carefully at our first 24 patients, and specifically to look at the precision and the accuracy of the lengthening. In other words, you know, if we're prescribing 1 millimeter of lengthening a day, what's actually happening? And we were delighted to find that the accuracy was actually 96% between what we had prescribed and what was actually happening. And this type of accuracy is fantastic. I mean, you don't get a higher accuracy than that with an external fixator. We became fascinated and totally engaged with this practice of using the internal lengthening nail. And we then, after we had developed more experience with it, we compared it to our previous experience of using an integrated technique of lengthening overnail. And what we found was that although the lengthening overnail was a really nice technique where we used the external fixator and a solid nail, the internal lengthening nail was just better. It was better, it was easier for the patients. The results were better, knee motion was better, healing was faster, and overall patient satisfaction and complications were better. So to give you an illustration of sort of the speed of recovery, I'm going to show you Jacob, who at the age of 16 with RSS presented to me with a 36 millimeter leg length discrepancy. And most of this was coming from the femur, so we did a femur lengthening. And we used a trochanteric entry nail because he still, his growth plates were closed, but in general, I tend to use it until about the age of 18. And you can see at the end of 2 months, he is healed. So it took about a month to get the length, and then by 2 months, there is hypertrophic regenerate spanning the lengthening site, allowing us to let him be full weight bearing. The timeline was as follows. At the time of surgery, we cut the bone. We identified the magnet inside the internal lengthening nail. We marked the skin with a magic marker so that the patient knows where to place the external remote control device. At 5 weeks, he's out to length, and you can already see the regenerate formation. And at 2 months, the regenerate is legitimately radiographically consolidated, and we can call this healed at that point. And at 3 months, we're already seeing quite a bit of remodeling, and the patient has already been full weight bearing for a month's time. So that kind of healing was very exciting to us and very exciting to our patients, and allowed us to do limb lengthening in a fashion that was just easier and safer for the patient. The technique of an antegrade lengthening is reviewed nicely in this surgical technique paper. That is the most common utilization of this technique is the antegrade internal lengthening nail for leg length discrepancy in RSS patients. Some of the technical details of the nail: again, it's a telescopic nail where this part of the nail elongates. It initially starts with a length of 30 millimeters sticking out. There's the ability to place 2 screws proximally and 2 screws distally, and there is a piriformis entry and a trochanteric entry option, and there is a retrograde option as well. I use the trochanteric entry for patients under the age of 18, and we use the piriformis entry for adult patients. The reason for using the trochanteric entry in younger patients is to prevent any injury to the blood supply of the femoral head and avoid any complications. When we calculate the length of the nail vis-a-vis the osteotomy, we have to take into account that there is a thick part of the nail and a thin part of the nail, and it's important to make sure that we have at least 4 to 5 centimeters of thick nail in the fragment that is moving and lengthening. So I'll illustrate a little bit on how I do that measurement technique. Here's a patient who has a 30 millimeter leg length discrepancy. The plan is to do the lengthening in the femur. Now, when you look at the lateral x-ray of the femur, you can see that there is a natural bow in most femurs, and there are different locations in different people. So in this particular patient, you can see it's at 170 millimeters from the tip of the trochanter. So that's going to be my osteotomy location. Now, to figure out the shortest nail length, the SNL, the shortest nail length, you take the osteotomy, which is 170, plus the amount that you want to lengthen, in this case, 27 millimeters, and you have to add 50 and 30. The 50 and 30 represent 50 is the amount of thick part of the nail that you want in this distal moving segment, and 30 is the amount of the thin part of the nail that's protruding right at the beginning before you even start. So by doing that, right, what you're assuring is that there is enough thick nail beyond the osteotomy, right? Here's the end of the osteotomy, and this is the thick nail. What we don't want is we don't want this part of the nail to be right at the osteotomy location, because this is not as strong as the thick part of the nail. And that's simply what this whole calculation is about, this SNL, or shortest nail length calculation. We use locking screws proximally and distally. I'll take you through some of the steps. These are still images from an animation that we put together on antegrade lengthening using the precise nail. The patient is placed supine on a radiolucent table with a bump under the ipsilateral buttock. We make it, once we have decided on the osteotomy level, as I showed you from preoperative planning, we make a small 1 centimeter skin incision, and we do multiple drill hole technique. Venting of the femoral intramedullary canal is the first step of the osteotomy. This serves 2 purposes. Number 1, it's the first step of the osteotomy, and number 2, this also serves to vent the canal of the femur so that the pressure is minimized within the intramedullary canal during reaming of an intact bone. This is to prevent the complication of fat embolism syndrome. So this is what it looks like on x-ray. We use a 4.8 millimeter drill. We use a soft tissue protector through that little poke hole incision, the 1 centimeter and skin incision, and we do multiple drill holes, typically at least 6 drill holes. Second step is a percutaneous entry into the proximal femur, whether it's the piriformis fossa or the trochanteric, greater trochanteric region, as I just mentioned to you. And once the guide wire, and I typically use a 2.4 millimeter Steinmann pin, and I check it on both the AP and lateral projections. Once I know it's in an optimal location, I can make a 2 centimeter skin incision over the wire, and then we can start the process of preparing the canal. We over-ream it with a cannulated reamer that creates an entry hole, and then we can start reaming the canal with a flexible reamer over a flexible guide wire. In general, we ream 2 millimeters larger than the nail diameter. Before the osteotomy is done, I like to insert rotational markers, and these are 2 Steinmann pins placed in the proximal and distal segment out of the path of the IM nail, and this prevents a rotational malalignment from happening unintentionally, or these markers can be used to correct rotational deformity if you know that you have a rotational deformity that you want to correct. But in the typical situation where there's no rotational deformity, these are placed parallel to each other so that we can make sure that that parallelism does not change. The guide wire is removed because the lengthening nail is a solid nail. The nail is placed up to the osteotomy location, and the osteotomy is then completed with an osteotome, and the nail is then inserted beyond. These are x-rays showing the technique. Here's a trochanteric entry nail. Here's the rotational marker behind, posterior or behind the nail. The nail is placed up to the osteotomy. Osteotomy is completed with the osteotome, and then the nail is passed into the distal segment. There is typically a tendency for a flexion or procurvatum to deformity to occur as soon as the osteotomy is performed. So a good strategy is just to lift the leg, and that will straighten the anterior bow by lifting the leg. You also want to anticipate the natural tendency for the bone to go into varus. But very quickly, the nail is passed into the distal segment, so you don't lose control over that. Once the nail is in the distal segment, I like to rotate a little bit around the nail to make sure that my osteotomy is complete. And I'm not really worried about that because I've got my rotational markers that make sure it takes me back to my starting rotation. Then the proximal and distal interlocking screws are inserted as shown on the schematic and on these intraoperative radiographs. What you'll see here is these are those rotational markers. And again, the marker is out of the path of the nail. It's typically distal to the nail. And in the proximal segment, it's posterior to the nail, so it does not get in the way. At the end of the lengthening, excuse me, at the end of the surgery, the position of the magnet is very well located and marked on the skin with a magic marker, with a Sharpie marker, and that allows the remote control device to be placed. This happens to be the first generation remote control. The current remote control is a lot sleeker and cooler. It's purple, and but it's the same idea. It spins the magnet, and then it turns the gears, and it elongates the nail in a very controlled fashion. Here's an example of a 16-year-old male with 45 millimeter LLD, and the discrepancy is coming from the femur. 16, he's busy, he's preparing for college entrance exams, doesn't have a whole lot of time, and being in a fixator for a period of 6 months would be very disruptive to his lifestyle. So we were able to do this in a fairly, I don't want to call it easy, but just much more simple approach using an internal lengthening nail. And within a few months, he's completely healed, completely consolidated, and really back to his full activities. We typically remove the nails 1 year after insertion, after we're very confident that the bone is completely remodeled and healed. You can see the shadow of the nail just for a week or two after the removal, where the screws were and where the nail was, and that all remodels and goes away. So here's Jonah, age 15 with RSS, and he has a leg length discrepancy that is 1 inch and has valgus alignment, right? And so as I've shown you, here we want to correct both the leg length discrepancy and the valgus alignment. We're going to use an internal lengthening approach, but we know that we're going to have to be thinking about using a blocking screw, right, in order to correct that valgus effectively. And that is in fact what was done. A fixator-assisted technique together with a blocking screw was utilized. You can see he made really nice regenerate. Again, the distal and proximal fibular length stabilization screws were quite important. And this is how the tibia healed very well. Grant, with a 20 millimeter leg length discrepancy in the femur, is being taken care of with an internal lengthening nail with a trochanteric entry approach. Also a very quick, reliable, safe treatment for him. But to illustrate the point that internal lengthening nail is not for everybody, Sloan, who at the age of 5 has a current leg length discrepancy that is 3 centimeters and predicted LLD of 6 centimeters divided between the femur and the tibia. So for her, the approach is going to be stage 1 lengthening with an external fixator, right? And then we'll come back as an adolescent and we'll do the rest of her lengthening in the femur using an internal lengthening nail. I do want to mention how helpful the internet and social media has been in terms of promoting awareness and fostering an informed community. You know, Russell Silver syndrome is a pretty unusual condition, and by using various hashtags and posting examples of patients and examples of treatment, we've been able to create and communicate with a community that is interested in what we have to say. And so this has been very, very effective in using Instagram, Twitter, Facebook, websites, YouTube, you know, using all of these modalities to try to help inform our patients about what we're doing. So in conclusion, there has been an evolution of lengthening and deformity correction. And principles do change, but they change slowly. But techniques do evolve much more quickly. And with new technology, tools change, techniques change. And when you have new tools and new techniques, your approach changes, and then paradigms shift. And that's what we have really experienced and taken the lead on, is creating paradigm shifts with this disruptive technology of internal lengthening. The tools that we have for lengthening are external fixation, integrated fixation, which is a combination of infix and exfix, or the fully internal lengthening approach. And you know, there isn't one technique for everybody, as I hope that I've shown you. We try to use the internal lengthening nail when we can because it's generally safer and easier for the patient, but there certainly are indications where the use of external fixation, or what we'll call the classic approach, or an integrated fixation technique, which is a combination of infix and exfix, is actually necessary. So I want to thank you for your attention. Thanks for listening, and I hope that this has been informative on leg length discrepancy, leg lengthening in congenital conditions, particularly Russell Silver syndrome.